You started recording, yeah? Good.
Awesome.
Good morning and welcome to Pediatric Grand Rounds. The code for the CME is in the chat box. Also, a quick reminder, please complete the evaluations at the end of the Grand Rounds. It's important to provide feedback to the speaker. It's my great pleasure to introduce this morning's Grand Round speaker, Dr. Chavan, who is Assistant Professor of Pediatrics, Inflammatory Bowel Disease Program at Children's Hospital of Los Angeles. She is a graduate of McGill University in Montreal, Canada. She completed her pediatric training at the Western University in London, Ontario, and her pediatric gastroenterology fellowship at the University of Montreal. She pursued an advanced IBD fellowship at the University of British Columbia, where she also completed a Master's of Health Sciences. She has participated in optimizing and standardizing the care of patients with IBD at her institution. Dr. Chavan research has focused in past on evaluation of therapies in inflammatory bowel disease, as well as therapeutic drug monitoring. She is a recipient of KL2 Career Development Scholarship, during which she has expanded her interest in point-of-care monitoring of disease of pediatric patients with IBD, particularly using intestinal ultrasound as a biomarker of disease activity. Her team is involved in assessing the multifaceted impact of intestinal ultrasound in pediatric IBD care. Dr. Chavan, thank you very much for accepting our invitation, and the floor is yours.
Thank you very much for having me this morning. It is a great honor to participate to this Grand Rounds. Here is my disclosures and some of the objectives for this morning. But one of my also main objective is to show you that intestinal ultrasound or point of care ultrasound has a role today in the GI clinic. So inflammatory bowel disease has is simplified into two phenotypes. So we often talk about Crohn's disease, or which has a demonstration of inflammation that's scattered throughout the GI tract from the mouth to the anus, versus ulcerative colitis, which is generally a continuous inflammatory process that starts from the rectum and goes to more proximal in the colon. But IBD is really a spectrum of disease that can have a presentation that emerge between the two phenotypes. It's called indeterminate colitis. So there's really a variety of presentation for inflammatory bowel disease. And similarly, the clinical presentation of the disease can be very varied. So we often think about diarrhea, rectal bleeding as the main way the disease presents in the clinic. Abdominal pain can often thought to be associated with it, weight loss and fatigue. Some more pervasive symptoms like micronutrient deficiency, growth stunting, and more specific symptoms like arthritis and skin or eye inflammation, which are also associated with inflammatory bowel disease. But as you may see, the main way that IBD presents in the clinic are non-specific, and therefore the disease can go undetected for some time because those symptoms can also be associated to be from functional disorders. So we can see that there's a wide spectrum of time from symptom onset to diagnosis of IBD, which can take up to, on average 4.5 to 5 months, which was shown in the first study in 2018 and also replicated through a systematic review with a longer time to diagnosis for Crohn's disease. But as you may see in the systematic review in this very smart chart, is the time to the diagnosis can be quite long sometimes, particularly in Crohn's disease, where that time can even spend years. And the longer the disease goes untreated, the more likely a child can have adverse effect on growth, on puberty, on nutrient absorptions, which can have long-term effect in terms of their growth overall or their growth potential. Not only is it difficult sometimes to diagnose IBD, the trends in incidence of the disease are increasing worldwide. So this has been documented for some time, and this more recent systematic review demonstrated that overall the trends in incidence of inflammatory bowel disease has been increasing worldwide, with a higher increase in Crohn's disease incidence as compared to ulcerative colitis, and that naturally progresses into an increase in prevalence of the disease overall. So in this model, this is a 4-phase model of the epidemiology trend through time. So you can see that in the Western world, especially with industrialization, there has been since the Crohn's disease got its name in the 1950s and onward, there's been a progressive increase in the incidence of the disease, which started to shift as other countries have become industrialized. And now in the developing countries, we're seeing similar trends. It is unclear yet why that is. There's a lot of theories about potentially with westernization. There's been change in dietary habits that may have promoted microbiome changes that are pro-inflammatory. But the general results from this is that the trends in the prevalence, so how many people suffer from the disease, is increasing. And that causes for gastroenterologists a diagnostic challenge, particularly in the fact that not only is it important to diagnose the disease early on, but monitoring has moved from using clinical symptoms as the main source of judging the effect of a drug to using more objective measures of disease activity, such as mucosal healing, and even in some scenarios, histological healing is thought to be the potential new age in a new target in drug efficacy. Why have we moved away from clinical symptoms alone as the source of judging the therapeutic targets? That's because over time, when we look at patients who do reach endoscopic improvement, so using it for ulcerative colitis an endoscopy subscore or Mayo subscore or 0-1, where we don't see any inflammation or very, very mild inflammation, we see that the risk of colectomy or surgical procedures is a lot lower as compared to those who have continuous inflammation over time, so an endoscopy subscore of Mayo 2 or 3. Similarly, in Crohn's disease, patients who do not have any ulcers over time, or what we call mucosal healing, have a higher chance of avoiding an ileocecal resection, as opposed to those that do have ongoing inflammation. So the best outcome is avoiding emergency room visit, avoiding surgical outcomes, and that seems to be improved. The risk of that seems to be improved when we reach endoscopic improvement. But we cannot do a colonoscopy all the time for all our patients. This is time-consuming, resource-intensive procedures to do. So can we use symptoms as a surrogate for endoscopic activity? And unfortunately, what we're noticing is that symptoms in IBD, particularly in Crohn's disease, do not correlate well with the endoscopic activity. So as you can see here in this chart, this is a graph looking at the Crohn's disease activity index, which is a symptom score for adults with Crohn's disease, as compared to the Crohn's disease endoscopic index of severity. We don't really see any correlation between the activity from one to the other, making symptoms a poor surrogate for endoscopic activity. Similarly, in Pediatric, so KinsCan is a pediatric inception cohort for a patient with Crohn's disease that were started in Canada. We see that the correlation between the weighted pediatric Crohn's disease activity index and the SCSCD, which is a simple endoscopic score for Crohn's disease, is also not very great, even though that was statistically significant, and the correlation may be a little bit better when the colon alone is affected as compared to the small bowel, which may give very little symptoms actually in patients with Crohn's disease despite having very active disease. Furthermore, about 40% of our patients, both with Crohn's disease and ulcerative colitis, suffer from irritable bowel syndrome. This is a collection of symptoms that are not linked to inflammatory processes, but does cause a lot of disability. Therefore, having active symptoms in IBD may not always mean that there's active inflammation in IBD, but the reverse is also true, that the absence of symptoms sometimes does not mean that there's no endoscopic activity going on. And the more we let inflammation fester without being fully treated, the higher the chance of bowel damage to accumulate in the bowel wall, causing narrowing of the lumen in Crohn's disease and occasional strictures, which then leads to surgery because currently in 2024, there hasn't been a drug that was found to be effective against scar tissue, but only against inflammatory processes in IBD. So this is a graphical representation of what we think the process is. So with every flare where there is symptoms that come up, there's actually a cumulative deposition of fibrous tissue in the bowel wall, leading a higher chance of surgery over time. And the risk of, once you have one surgery in Crohn's disease, the risk of surgery, subsequent surgery becomes quite high. We used to think that for ulcerative colitis, as a mucosal disease, that there was not cumulative bowel damage. But this thought process has changed in the past, I would say 5 to 10 years, where we have noticed on pathology samples that there is fibrous tissue deposition, even in the colon of patients with ulcerative colitis, and that a similar process is ongoing in those patients as well. This process may not cause always narrowing of the lumen, but it does cause bowel dysfunction, symptoms of urgency, which can be quite disturbing to patients, so having to rush to the bathroom when they have a bowel movement. Furthermore, having ongoing inflammation in the colon can lead to mucosal changes such as dysplasia and a risk of colon cancer, which is actually quite high in patients with ulcerative colitis who are not fully treated or have ongoing inflammation for many years. So how do we change that? We've noticed that monitoring objectively the disease over time can change the rates of reaching endoscopic remission or having complete reversal of inflammation on colonoscopy. This is a seminal study called the CALM study, where they compared a group of patients followed only clinically with clinical symptoms and blood work such as CRP to decide on optimization or change in therapy every 3 months, as compared to using objective measures, primarily meaning, yes, CRP, but also fecal calprotectin, which is thought to be more reliable marker of endoscopic activity for IBD every 3 months in the process that we call tight control or treat to target. And by having this tight control protocol using fecal calprotectin every 3 months, then they notice that they have an increase of 15% in reaching this endoscopic remission in those patients. And once you reach endoscopic remission, so we've noticed that we're now entering disease modification, because those patients who have reached endoscopic remission in year 1, defined as Crohn's disease endoscopic index of severity less than 4 and no deep ulcers on colonoscopy, have a more avoidance of emergency revisits, steroid exposure, and surgery over time. And if you make the definition more stringent, so deep healing, which would include endoscopic remission, but also clinical remission and no steroid exposure for more than 8 weeks prior to the year mark, then you have an even wider demarcation between the two groups in terms of avoiding complication of disease that was defined as emergency revisit, again, surgeries, and steroid exposure over the subsequent year. But again, can we do endoscopy, every 3 months? Do we only rely with fecal calprotectin? So we have moved to try to look at what are good surrogate markers of disease activity that we can use easily in the clinic, so that we can know what the disease activity is on top of asking our patients about their symptoms. But each surrogate markers of disease activity have pros and cons. So if we look at endoscopy, which is really our gold standard, we can see the disease, we see inflammation. It's a way for us to have histology as well, to look at microscopic activity, but also if there's complications or polyps, we can see that and collect that and make sure that there's no severe complication of disease. However, for patients, especially children, we're talking about general anesthesia every time. There's time loss for the parents and the child from school and work for 2 days, actually, because the day before they have to do their cleanup prior to the procedure, and repeatability is difficult, right? We have to have OR time, staffing, and availability to be able to do that in a growing population of children with IBD. So this is not a very feasible way, not to mention that acceptability amongst families can be very varied over time. Biochemistry, it would be ideal as it's non-invasive and easy access. Obviously, a lot of kids do not have needle phobia, so that can be a challenge, but most children can tolerate it quite well. However, inflammatory biomarkers are not specific. They're affected by any intercurrent illness, which can be frequent in children, and also by any associated disorders. So some children have associated juvenile arthritis or spondyloarthritis that can also play on these markers. So it's not always representative of the gut disease. Fecal calprotectin, as I mentioned before, is a stool test. It's a measure of protein extracted from granulocytes or shed by granulocytes in the colon, and is thought to be a more reliable marker of intestinal activity. So it's non-invasive, it's easy access, hopefully most children poop once a day to collect that. But there may be challenges in coverage, and not all states have the same coverage for insurance for fecal calprotectin, and sometimes it can be quite expensive. Children don't want to collect poop. It's not our most popular test to do, so having it come back as a result tends to be difficult. And in small bowel Crohn's, specifically at times, we can notice that the number is not very impressive despite having active disease. So not in all scenarios of IBD is calprotectin always a good marker. And finally, CT-MRE, or non-invasive ways to look at disease. It's a direct visualization of the bowel. Much better to assess small intestine than colon, but it can give us a result for that as well when there's severe disease. But again, access is difficult for the CT. Radiation is something to consider. There has been some concern about gadolinium exposures, but some protocols for MREs are coming out using no gadolinium as contrast. And repeatability can also be difficult because oral contrast is not easy to drink for all kids, and having the volume can also be a challenge. So this is our commonly available ways to assess disease, and all of them have pros and cons. But when we look at adherence to treatment targets for a population, this is a study for an adult population in an outpatient clinic. We see that you're looking at clinical assessments, so coming to a clinic visit is really where we have to maximize our time, because patients are more likely to come to their clinic visit than do anything else that we offer. If we compare to a CRP, which is a blood test, then the acceptability or adherence to doing that test drops quite a bit. And then when we look at the stool test, then, if we only relied on that to measure inflammatory activity, then only a third of the time will we even have a result to be able to make decisions on. So partnering with our patients to really find ways to assess them reliably and consistently is important. In 2015 and then revised in 2021, the STRIDE guidelines that was now at their second iteration discussed about monitoring protocols for a patient with IBD. And it really emphasized the importance of having these interim markers of symptoms or disease activity, I should say. So early on, we do want to have symptom response and have our patients active again. But in the short to medium term, what we want to see is normalization of those markers, and ideally a normalization of growth, weight gain, and stool calprotectin as a most reliable markers of activity, and using endoscopic as our long-term target, within 9 to 12 months as the marker of really having success with our therapies, which should lead naturally to an improvement in quality of life and absence of disability in our patients. Already we have started to talk about transmural healing as a potential target, and that has quite changed in the recent years. So we are now entering this era of disease modification, we have more therapies available to treat inflammation in an effective way. And how we use these medications is important in terms of ensuring long-term outcomes. So we want to have an early and accurate diagnosis with a clear phenotype of our patients, which help for us determining prognosis over time, and also assess extraintestinal manifestations of the disease, or EIMs, that should be treated separately or concurrently with the inflammatory bowel disease. Once we induce remission, so those are the early process of having our patient feel better, the induction phase is aimed at having clinical remission so that our patients are going back to their lives, being active and, being able to go about their activities, but also starting to see a trend towards normalization of their lab growth and nutritional status. Then over time, we want to maintain this remission. So we want to see that the disease remains controlled over months to years that follows. And we do need optimized ways of monitoring that, because at times the inflammation will start creeping back before the patient even feels unwell. So we want to be able to maintain remission by being proactive at detecting disease activities and treating it early on. And finally, health maintenance and prevention is very important for our patients. So monitoring the subclinical relapses, treating them effectively and early on before the patient feels sick, having infection and cancer prevention through screening and vaccination. For children, bone and nutritional health is very important to make sure that they're going through puberty and reaching their growth potential, and also maintaining the success through a prepared transition to adult care. We are still facing few barriers in reaching those goals. So as we talked earlier about, there's delays in diagnosis and treatment optimization because of referral to GI, or even being suspicious of IBD as a diagnosis, the availability of results when you get to GI, because often we have patients coming with no specific blood work or findings at times that indicate that path. Availability of diagnostics, sometimes wait times can be a little bit difficult to navigate, and there may be also hesitancy from parents and children to undergo those invasive testing to get to a diagnosis. There's still no great way in 2024 to pair the perfect patient to the right therapy, especially as the number of biologic now available for IBD are increasing on the market. And the test tolerability, as discussed before, has to be a consideration because some of them are not popular, but we do rely on these results to move forward in care. So potential solutions have been to create more precise pathways, or through education and more direct referral pathway to GI to get to early diagnosis. Maximizing point of care testing through non-invasive monitoring tools are important, because the clinic visit becomes our most reliable time where we can really maximize the results that we get. Having objective markers of disease as our main way to optimize treatment, even when the patient feels well, is important to maintaining the success of our therapies. And having this treat to target management algorithm is the way that we can get to that success quickly and maintain that success over time. And having unprepped, unsedated real-time analysis also helps to reach those conclusions a little bit more rapidly right in the clinic without, impeding on the clinic time spent by the patient there. So overall, this part of the talk was meant to highlight that there are diagnostic challenges with IBD, especially as the most common symptoms are not specific to IBD and can be seen in any infectious disease or functional disorders, leading to some diagnostic delays. And furthermore, there's trends that shows that worldwide, and definitely in the Western world, there's been increasing tendencies in incidence and therefore prevalence of the disease that causes some burden on the healthcare system to accommodate this, especially if we rely on invasive ways in monitoring our patients. So having objective disease activity targets are important, but finding some that are available right at the bedside is a way to maximize our patients' time and the number of results that we can use to treat them moving forward. And these non-invasive options should be easily repeatable, but also be accurate in depicting disease activity and have acceptance for our patient. So if I talk a little bit my trajectory, which you've heard a little bit, I'm from Montreal, Canada, and Canada has a very different healthcare system. So as compared to here, so we had our own challenges in getting access to certain in tests, particularly in radiology for our patients. And I've noticed while through my travels for medical school residency and fellowship that there are similar challenges everywhere. So from Montreal, I did a pediatric residency, as stated, in London, Ontario, then went back for my GI fellowship where I really fell in love with inflammatory bowel disease and all the potential, especially at the time, infliximab had just become a little more routine in our care, and we were still learning how to optimize that therapy. So I've pursued this advanced IBD fellowship in British Columbia, which is a combined adult and pediatric IBD fellowship, where I've started to see the contrast and differences between care between adults and children, but that the common theme is that some of these testing are not very popular and not easily repeatable in both scenarios. And then I went back for some work in Montreal for a few months until I landed here in Los Angeles, where I've been practicing and trying to apply some of the things that I've learned. But lo and behold, even from Canada to our center, well, I did notice that there are some long wait times to get MR enterography for children, which was a challenge, right? If you have a patient who's diagnosed, and you can only get an MRI 2 to 3 months later, by then we started to treat the patients. We don't know if the distribution of disease is the same as diagnosis, so we don't have a good idea of the phenotype of our patient by that time, because the colonoscopy really misses out on a large part of small intestine that could be affected, particularly in Crohn's disease. There's some wait list, more so in Canada, but there's still a wait list for having an upper and lower endoscopy under anesthesia, and that can lead to delays in treatment initiation, which is not ideal. So that's where implementing intestinal ultrasound in the clinic becomes very practical. So it's a quick examination. In a routine patient, it can take 10 to 15 minutes. It can be longer in a complex patient. But for all of them, it's non-invasive, it's painless, and can be accessible when you have equipment, and really does not require any preparation or fasting, although it can have some limited results in certain body habitus. But especially with new technology and the resolution of the new transducers, this is becoming less and less of an issue over time. So intestinal ultrasound has already been featured in clinical guidelines, both in the United States and in Europe, where it is featured as one of the ways to diagnose and monitor treatment response over time. What we look at is really the details of the bowel wall of the patient. So here you can see a depiction of what a normal bowel wall would look like, with different layers such as the mucosa, submucosa, muscularis, porphyria, and serosa. And once there's inflammation that sets in, you have expansion of these layers, maybe blending of these layers, like loss of stratification, and having periintestinal inflammation also show up as periintestinal fat. This would be an axial view versus a longitudinal or transverse view of the bowel, where you see the normal layers that should be quite defined on ultrasound in a normal patient, but when inflammation sets in, again, you have expansion of certain of these layers, and they can also blend and lose definition. So below you can see intestinal ultrasound images in the axial view with Doppler activity to increase blood flow within the bowel wall, and a longitudinal view similarly showing a depiction of each bowel layer, so the mucosa, submucosa, muscularis, propria, and a little serosa on top. This is one of our patients. So this is a new diagnosis of Crohn's disease. As you may see in the depiction previous, we have an axial or kind of oblique view with increased Doppler activity in the bowel wall. What's nice is that we can also see in real time um, the bowel move, the peristalsis sometimes, and have really good idea. We can follow the bowel through ultrasound and see the length of disease, especially when it's shorter disease, more difficult when it's a very diffuse, patchy disease. But we can have a good idea of this inflammatory activity. And this is the corresponding colonoscopy where we had terminal ileitis with a lot of edema, some cobblestoning, and deep ulcerations. So intestinal ultrasound becomes a very nice way to directly visualize the disease activity right in the clinic. So as stated, what we look at is the bowel wall. So the most significant feature is the bowel wall thickness, or that measurement from the mucosa muscularis, submucosa and muscularis. Those three together forms the bowel wall thickness that we measure. You can see a measurement here about 2.3, 1.8 millimeters. And when there's inflammation, this number, the bowel wall thickness, starts to increase. Now we have 4.37 millimeters in thickness in this inflamed portion of transverse colon. It's usually we call the bowel wall inflamed when it is above 3 millimeters, and this is extrapolated from adults, but we're noticing that probably in children, this is not as accurate because in younger kids, we may see inflammatory features without having those measurement cutoff present. There hasn't been any specific cutoff value generally accepted, but we value probably 2.5, 3 millimeters. But for now, the guidelines have extrapolated from adults the cutoff measurements for children. But as you may see in our little friend Leo, who nicely agreed to be on picture, we often don't see that in younger kids. Leo is 6 years old. His bowel wall thickness was probably like 2 millimeters, 2.5 millimeters. But yet when you put a Doppler signaling, he had a lot of activity there, and he was slightly symptomatic with some bleeding. So we're still working as, an intestinal ultrasound enthusiast community in defining what would be accurate cutoffs for children. And looking at children in remission from IBD, this is a study that we conducted as a multi-center study. We've noticed that when they are in remission, the bowel thickness are extremely thin, about 1.4 millimeters on it as a medium measurement, and that most of the patient will have a bowel wall measurement under 2 millimeters. So we're starting to approach that possibly this should be the measurement that we use as a cutoff for children. Other features that we look at for intestinal ultrasound, one would be hyperemia. So that's the presence of blood flow. So as you may see, when there's no signal, this bowel is healthy. Here, there's really no signal that can be picked up. The flow is just too slow for the machine to pick it up. And then as you start to have more and more inflammation, you start to see some short patches or signaling, and then long patches of signaling. And then you can even have signaling inside and outside the bowel, almost like a Coombs sign distribution, and that demonstrates severe disease. We also look at stratification, so how well we see this Oreo cookie pattern or having the mucosa, submucosa, and muscularis. And this pattern should be preserved in, moderate, milder disease. But when it becomes very severe, we start to lose that definition, what we call loss of stratification. And inflammatory fats, so the tissue around the bowel can also become a lot more prominent. You can almost draw a circle around it. That becomes another sign of intestinal inflammation. So if I show a case, this is a patient who presented to my clinic in May, I want to say, of 2023. He had had some abdominal pain and weight loss since November 2022. He had already had a colonoscopy, which report he brought with him, and it had described some redness on the upper endoscopy and the normal colonoscopy. He was treated with a proton pump inhibitor for some time, but he continued to be symptomatic, and around the time of the colonoscopy, the calprotectin was 1,000. He had not had any, he did not bring any other labs with him, and the calprotectin was still pending from a few weeks prior. So that was the information he came in with. So we did our ultrasound in clinic, and this is a sigmoid colon, wasn't very impressive. As we get to the transverse colon, we start to see some activity there, and then the ascending colon was absolutely abnormal. So it was surprising that he had had a normal colonoscopy anytime before, because that was quite advanced disease, and the terminal ileum was quite involved. So at this time, I could confidently tell the parents that this is likely a diagnosis of Crohn's disease, and we can then expedited his workup and treatment from there on. Intestinal ultrasound is pretty comparable to MR enterography, at least for detect inflammation. So if I increase the size of the sensitivity specificity for both tests, you can see that they're quite similar. I could argue that both modalities can be have performance dependence for the readers, and having somebody train, especially only in bowel, can increase that sensitivity, and that was the case in this study, in the systematic review. We looked at our center for the comparison between a point-of-care intestinal ultrasound compared to MRI, and we had moderate reliability compared to the two, looking at the kappa, which was 0.5, particularly because of the colonic. MRE is not always very accurate for the colon, especially in mild disease. I could argue as well for intestinal ultrasound in mild disease, very mild disease, it can also sometimes be lackluster, but anything moderate disease to more active disease, colonic sickness become very clearly prominent. In pediatric patients specifically, looking at the reliability of intestinal ultrasound to colonoscopy, then we start seeing a wide range of sensitivity and specificity, but in a very trained expert level, we can reach a reliability of or sensitivity specificity of almost 100%. So we're really based on training of the provider, and we do see an association between the thickness of the bowel wall with the activity on the endoscopy. So mild, moderate compared to severe would lead to an increased bowel wall thickness on the ultrasound. We did our own study at Children's Hospital Los Angeles and noted that similarly that for patient with Crohn's disease, we had for individual bowel segments using a segmental simple endoscopic severity index for Crohn's disease, that the bowel wall thickness was associated with severity of disease, and it was similar for a patient with ulcerative colitis, although the bowel wall thickness wasn't as prominent in some cases. And we tried to extract this data to come up with that cutoff measurement. And we've noticed that pretty much across all bowel segments, using a 2 millimeters probably will be the most accurate cutoff that we come up with. But having a more diverse population of children to validate those measurements on will be very helpful. We also looked at the likelihood of predicting the diagnosis of IBD. So Crohn's versus ulcerative colitis has the diagnosis, and then Paris classification, which is a way we describe the disease distribution in patients. So naturally, it will be affected by the diagnosis we give. The Paris classification has different classification based on if it's Crohn's disease or ulcerative colitis, but we saw that at least agreement between ultrasound and colonoscopy was at roughly 70% for Crohn's disease and ulcerative colitis, and then the Paris classification was about 45%, considering it's affected by the final diagnosis that we give. So using Cohen Kappa as well for the diagnosis was moderate reliability. And when we do that Paris classification, use it weighted, so meaning that if we skip 2 categories, it'd be a bigger loss than if we skip 1 category over of inaccuracy. We see that similarly is about moderate between ultrasound and colonoscopy. Where else can ultrasound shine? So sometimes a colonoscopy can be incomplete for various reasons. Either the colon was too severe to complete, or there was complication. And you can see that in this study, about ultimately a large percentage of the group had a benefit in having the ultrasound, and even decisions on disease management was made only on ultrasound. Big alone. So it really can help complete or understand the disease distribution in many ways. So in this patient, we had a patient who was mildly symptomatic. He complained once in a while of abdominal pain, but he did have a very high calprotectin that we could not fully understand. At the time, he was on a biologic medication called adalimumab, and he had a normal upper and lower endoscopy. So the major issue was that his weight gain was quite slow, and he always stayed around the 5th percentile. But when we did his ultrasound, what you see is this. Oh, my internet is becoming a little problem, but basically what you can see, this is a video, but what you can see is this very inflamed segment here, but underneath, if the video was working, you could see the terminal ileum, the normal terminal ileum that we could see that actually appeared normal. So you can understand that the disease that we were actually chasing was more proximal than what we can reach via a colonoscopy. Intestinal ultrasound can also be used to track disease over time. So this is a study of a patient with Crohn's disease and looking at the finding of endoscopy over time. So at baseline, which is a dark line, and with 3 months, 6 months, 12 months on the lighter bars. Over time, we can see that the percentage of patients who reach normalization or who have detected activity based on the measurements that they use as cutoff decreases over time when you change a therapy for Crohn's disease. And there's also like potential for early response of Crohn's disease over time. So this is a study called Stardust, and it was really a clinical trial looking at treat-to-target approaches, kind of like the CALM study, but using a medication called ustekinumab. So the goal was to look at treat-to-target versus no treat-to-target, but they had a parallel arm that monitored with ultrasound throughout the studies. And what they noticed is that the earlier changes, especially in Crohn's disease, where usually we think about, okay, by 3 months, perhaps we can start seeing improvement. They actually saw that there was starting to be a change in the bowel thickness and ultrasound findings by 4 weeks after treatment initiation. And that's more becomes much more significant than at 16 weeks. So there may be early findings that we can focus on to at least make sure early in our treatment course that our therapies are working. Looking at ulcerative colitis, similarly, this is a group out of Germany that had a big study throughout multiple centers, about over 20 centers in Germany, and they monitored patients with ulcerative colitis after a change in therapy, and noticed that even as early as 2 weeks, we can start to see changes in bowel wall thickness, and also for other features such as loss of ostration, improving over time, loss of bowel wall stratification, and so on, that improve rapidly in patients with ulcerative colitis. And again, so that highlights the role of ultrasound even as an early marker of treatment response in that patient group. For clinical decision-making, ultrasound can be quite helpful. This study looked at physicians' plan or a management plan in the clinic. So they had 2 physicians come up independently with a plan based on clinical findings and blood work for their patients. And then a blinded reviewer did an ultrasound and then presented to each physician the ultrasound results, and they looked at how this changed their management plan. And as you can see, there was a change in their management plan. 60% 50% of the time, roughly, for both providers. So ultrasound does add an extra layer of confidence for the management plan, but also can change the management if you do note asymptomatic disease activity or complication of disease that should be addressed at that time. And during COVID, this had become for this group out of Calgary very important because endoscopy time had become quite limited, particularly in Canada. And they had to pivot on how they would assess their patients who had active flares. So they put together this flare clinic that had either in-office sigmoidoscopy and ultrasound available. And they noticed that for almost 70% of patients who had ultrasound only, they could avoid all acute care or hospitalization for endoscopy. And for those who had the in-office sigmoidoscopy, all of those patients who only had that could avoid further evaluation. And for both, it was roughly 90% for those who required both procedures. So it was really helpful for that to avoid more burden on the healthcare system at a critical time in our history. But also for a patient who had ultrasound, only 80% of the time they could make a clinical management plan based on having the ultrasound. Ultrasound can also be helpful for determining disease complication. This is a study done in radiology, however, and they look at the reliability between multiple. So this was, there's two CAPAs because there was 3 raters. So for determining strictures, inter-rater using ultrasound, but also as compared to MRE. MRE can be more specific, particularly for enteroenteric fistulas and abscesses, but when the disease is, depending on the location, ultrasound can also be fairly accurate, as you can see by these numbers. And we can enhance ultrasound by using our external markers such as fecal calprotectin. This study was specific for a patient who had an ileocecal resection, so a small bowel and colon resection for stenotic disease. And we monitor this patient for disease recurrence because it typically recurs at the site of the surgery. And as you may see, adding fecal calprotectin was helpful in increasing the sensitivity of the test. So this patient is, hopefully my video works this time, was recently switched from to a new drug to that was our previous patient who didn't have, small bowel disease I could detect. He was switched to a Stelara. His dose was optimized, and over time he became asymptomatic. However, we started to see this swelling in his bowel, and this video demonstrated a stricture that now we could see in clinic. So we could monitor that stricture dilation over time and referred him promptly to surgery for assessment for a resection. Another patient that we saw here had appendicitis a couple of years ago, had ongoing abdominal pain, had an XLAP that showed quote-unquote inflammation. When he came to our clinic, we could see this abscess in the pelvis with a fistula to the GI tract here. And on Doppler, the associated loop of bowel was quite inflamed. So that made, based on this history as well of 2 years of these symptoms, prompted the diagnosis of Crohn's disease, and he was re-referred for an ileocecal resection. Perineal abscess. So we're starting to develop more techniques in using intestinal ultrasound, and one of it would be to do perineal ultrasound in the clinic. This patient had multiple therapies in the past and was finally on adalimumab and stable, but she developed this lump on her bum area that was bothersome, came and went. She was never febrile, never really felt unwell, but it was kind of bothersome. And when we did the ultrasound in clinic, we could see this pocket of fluid right in this area and could diagnose her with the perineal fistula and abscess and send her to surgery for drainage. So there's a few advanced features that can help enhance. I will briefly touch on these. So using contrast can help highlight abscesses and fistulas. It does require placement of a IV and uses bubble contrast, so probably best done in the radiology unit as compared to a fast-paced clinic. Transperineal ultrasound, as demonstrated, can be very helpful to look more specifically at the rectum, because transabdominally we can miss that segment most of the time because as it's dependent on bladder filling. So having a perineal approach is helpful in looking at the rectum and also looking for perineal fistulas and complication that way. And finally, there's hope to use elastography at some point to look at stiffness of the bowel and be able to predict scar tissue as compared to inflammatory strictures, which could be responsive to therapy. There needs to be a lot of optimization of this technique. There's a lot of difference between ultrasound systems, but we are hopeful that with standardization and more research, eventually this will be a treatment outcome as well. But where intestinal ultrasound really shines in the clinic is really this discussion with our patients. Our patient actually really sees those findings and how they change over time. They're reassured. Some patients actually rely on the ultrasound to really feel good about how we're moving forward with therapy. And it really changes this conversation. So this study looked at how ultrasound changed aspects of knowledge of IBD in their patients, and particularly in active patients, which we can argue are the ones who should be more activated. We see that the patient reported more knowledge of their disease, they understood their symptoms better, and they were more at ease with the decision that they made with their physician in the clinic. So those are all things that I want my patients to feel good about once they leave my clinic. And I feel like the intestinal ultrasound does become a pivotal point in that discussion. We also see in the pediatric patients that both caregivers and the patients are quite satisfied with their procedure, and overall their patient experience is enhanced by having intestinal ultrasound. There are some limitations. It's not a perfect tool, so as we talked a little bit about histology and how it can potentially become a marker of disease activity over time, we've noticed that intestinal ultrasound is not the best marker to predict histology, and there's still some research being done to understand if that could be a role. And we can increase the reliability of the score using fecal calprotectin. So having both an intestinal ultrasound and fecal calprotectin is the most ideal, especially in those mild patients that can have more non-specific finding or subtle finding of ultrasound. So as stated, it's not the best for very, very mild disease where the findings can be subtle, especially for somebody who's newly trained into intestinal ultrasound. If the disease is limited to proctitis, as discussed, seeing the rectum transabdominally is limited by bladder filling, and so this cannot be predicted in clinic. So a transrectal or transperineal approach tends to be better in those cases, and it's definitely not the way to diagnose dysplasia or colon cancer surveillance, and that will always require a colonoscopy. It does not permit immediate intervention. So if there's concerns of a stricture that needs to be dilated, we clearly cannot do this yet with ultrasound. There's for patients who are very complex, had multiple surgeries, probably reserving more time is important to have a very clear view of all bowel segments. And in patients with higher BMI, it may be also a more difficult exam, although some recent studies have not shown that it was a problem as compared to a patient with regular BMI. So there's still a lot of ongoing questions, especially in pediatric, where we haven't fully validated the technique, and that we still need to work on defining our cutoff, defining remission, defining response to therapy, and also understanding that different therapies may have different timeline of response. So we may not expect always to find the same rapidity of response on ultrasound across all of the biologic that we have available, and understanding that transmural outcome may not signify mucosal healing, So sometimes you have mucosal healing, but you have transmural activity, and we don't yet know what that means for our patients with IBD. So finding ways to incorporate this into the treatment algorithm or the monitoring algorithm of the patient in an accurate way, especially in the maintenance period, is important. And then understanding how this tool become cost-effective, or is it cost-effective at all? Currently, it's being done by physicians. Is that the most cost-effective way of integrating intestinal ultrasound in this clinic? That is still to yet to be demonstrated. We have conducted national efforts to disseminate the use of intestinal ultrasound, and there's a lot of ongoing training happening for that. And if there's ever any interest from the GI group, here is the email for IU-Scan to join the group and also participate to the monthly educational sessions that we have. So in conclusion, intestinal ultrasound is a patient-friendly tool which helps to make clinical decision in the clinic. It's fairly comparable to many of the diagnostic tools, particularly when we're looking at really tracking the inflammation over time, and additional testing in radiology can be added when clinically indicated. And it is also very helpful in the context of this increasing incidence of the disease in screening for disease activity in clinic, especially in these undifferentiated patients. I just want to acknowledge all the group that's been supportive of my research and my endeavors in integrating this into our clinic. And with that, I will take any questions.
I wanted to ask a question. Thank you very much for this really interesting presentation. It has to do with the last part you talked about, and I would say maybe protecting the quality of your skill or who should provide the skill. So I'm wondering, and especially does insurance pay for this, and who can just submit something and get paid? So how is training in these ultrasound techniques becoming a required part of fellowship, or just talk about the quality there and what people need to do to be assured that this technique is being done to the best of the ability, and then who reimburses for it.
So to talk about training, the training has been spearheaded by the Intestinal Bowel Ultrasound Group, which is an international group that has a tiered model. So there's a workshop that's kind of a hands-on workshop where you get your introduction, start seeing images, and then there's a hands-on portion that's 4 weeks mandatory. The number of cases to finish that workshop is 40, but we know that probably more exposures and definitely the centers that offer training reach much larger numbers than 40 at the end, so that the trainee becomes more comfortable about seeing the images, getting the right identifying the right portion of bowel, and start seeing complications. And then there's an exam as a module 3, and also a kind of an update on the state of the research in that area. So currently the credentialing processes through hospitals has requested that this full certification has been completed. And in terms of quality control, I think as a community, this is something we're still working on to make sure that the care that patients are having is consistent and good. Currently, it's not offered there's just not the volume. When I started in 2020, we were just in pediatric 2 institution plus a Houston that were doing it in adults. And now there's more centers doing it, like probably around the 30 mark between adult and pediatric GI. And we've focused a lot on training GI providers first. Because the community is still small, we know who's doing ultrasound. We have ways to kind of know where the skills lie. But as this is growing, we're talking more and more about how maintenance of certification will occur, and how do you demonstrate that you are providing good care. So this is a working process. In terms of billing, sorry? Do you have a question? I didn't want to cut you off. I guess to complete, in terms of billing, there are codes that are reimbursed by some insurance, but IU-Scan is currently working on creating new CPT codes that would become more specific to intestinal ultrasound, so that we can separate it from the radiology codes, and also permit more tracking through the country, and just to know how this is impacting care overall.
Yes, thank you. Yes, I'm not so much concerned about the people being trained. I'm concerned about who can say that they did it and get paid for it. That would then detract from the people who are really trained to do it and do it correctly.
Right. At this point, the most hospital credential process for ultrasound has requested that it's gone through from the institution that I know, it's request that you show certification through IBUS to be able to practice and bill in the institution.
Great. That's great. Thank you so much.
Have you used intestinal ultrasound at all to evaluate necrotizing enterocolitis?
I haven't personally. Our NICU is interested. I've seen research done in that space, so I think it could be a possibility, but I haven't yet ventured there.
Thanks. Wonderful talk.
Thank you.
In that same context, we all have our favorite intestinal diseases. I'm an allergist, and sometimes there's intestinal anaphylaxis, we call it. So it's isolated allergic reaction, and they don't have other manifestations. And another example is hereditary angioedema, where they have bowel wall edema. Have you encountered that in the literature? Or have you had an opportunity, or your colleagues looked at sort of non-specific bowel
for
pain
sure.
and
So
edema?
Yeah. So that's an interesting question. There's very few papers looking at that. So one of our colleagues was interested in allergic enterocolitis, and we've been starting to scan a few of her patients. We growing a small cohort of these patients. The findings are subtle, so I think having a longer experience in ultrasound would be helpful, because they're so subtle that it would be hard to describe in a paper. The bowel thickness is not significantly different, but there is swelling of the mucosa, and that's kind of hard to describe in numbers. So I'm still trying to see how to describe, and if those findings are actually really linked to the enterocolitis before really making those diagnoses based on ultrasound. I would say that it's very subtle, similar to there's some papers looking at celiac disease and ultrasound, and all these findings are a little bit subtle. So my biased opinion, and I've read it, very biased opinion, is that there are changes that could be tracked, because we've seen it in the allergic with like food exposures and versus not, and they were quite different. But describing that in a way that would make sense scientifically, I think is a part I'm still a little bit struggling with. But yeah, it is an interesting.
Well, I agree with you. In the hereditary angioedema literature, they can detect bowel wall edema. It's discontinuous, and
Right.
they can confirm it with MRI, and that's the most sensitive for detecting the edema. And so I might encourage your colleague to talk to your allergy department there and to see if they follow people with hereditary angioedema with abdominal swellings. That might develop more sensitivity based on that, and then move to some of these other trickier conditions.
Absolutely. That's a great suggestion. Thank you. Well, I guess we're at time, but thank you so much for joining this morning.
Thank you so much, Dr. Chavanez.
Thank you.
Thank you for joining us.
Have a good day.
I'm going to go ahead and conclude in the meeting. Thank you so much.